to the virtual skull-based webinar series session 3. We encourage you to submit your questions or comments using the chat box throughout the presentation, which is identified by the speaking bubble icon at the bottom of your screen. I will now hand it over to Dr. Bambakidis.
Thank you, Pam. It's a pleasure to welcome everyone to our third session, virtual session of our Skull-Based Fellows course. Today will be the first part of our review on the transmastoid approaches. We'll be focusing on the retrosigmoid approach. We'll also review the middle fossa approach. And really the way we'll structure this, in addition to having some dissection examples, is a little bit of a decision-making session with respect in particular to the surgical management of acoustic neuromas, utilizing not only the potentially the retrosigmoid approach, middle fossa approach, but also talk a little bit about the translabyrinthine approach, which we'll review in detail anatomically during part 2. Moderating with me today will be Dr. Sarah Mowry. Dr. Mowry is an associate professor in the Department of Otolaryngology at University Hospitals and Case Western Reserve School of Medicine. And our lead lecturer and operating surgeon is Dr. Ashok Ashtagiri from the University of Virginia. Again, reminder of the upcoming webinars in this series on November 5th. Same time, we'll be reviewing part 2 of the transmastoid approaches, focusing on the translabyrinthine approach, transcochlear approach, and combined approaches on November 19th. Will be the review of the far lateral approach and variations. And finally, our last session will be on December 3rd, concluding with anterior cranial fossa skull-based approaches, in particular the orbitozygomatic approach variations, including anterior clinoidectomy as well. As a reminder, all of these will be recorded also. Again, our annual meeting planning is well underway. Please review the agenda at cns.org/2021 for that meeting in Austin in the middle of October next year, under the leadership of Dr. Ho. And also, as a reminder, review all of our educational products offered by the CNS as highlighted here. In particular, again, I'd like to highlight Nexus. Many of the cases that we'll be showing today can also be found on the cns.org/Nexus site, where they can be reviewed in greater detail, and additional anatomic examples can also be found. And I'd also finally like to thank Medtronic for their silver level support for our course series, Carl Zeiss, Meditech and KLS Martin for their bronze level support, and Olympus America and Spieway for their educational grant in support of our 2020 virtual skull-based webinar series. So with that, I'd like to turn things over to our lecturer, Dr. Ashtagiri, who will give us a review of the retrosigmoid approach. As a reminder, you can ask questions through the chat box, and we can answer those as we proceed through this morning. Ashok?
Thanks, Nick. I think everybody can hear me okay. I'd like to go ahead and get started.
Yeah, we can hear you.
Okay, good. Okay, first, thanks, Nick, and to everybody at the CNS for inviting me to participate in this skull-based course and asking me to speak about retrosigmoid approaches. And I have no pertinent disclosures, and just hopefully, as we go through this, we'll have a very practical understanding of the approach to the retrosigmoid region and what it can afford through this avenue. Before I get started, I wanted to provide a few acknowledgments to folks that I've worked with over the years who have helped developed our microdissection lab here at the University of Virginia, and have also been my partners in obviously doing these surgeries. Kaan Yagmarlu is a neuroanatomist who worked with Al Roten and has a anatomic dissection laboratory here. You'll see some of his images throughout this presentation as well. Of course, a lot of the figures, rightfully so, are taken from our Bible, the Roten Cranial Anatomy and Surgical Approaches Compendium that was put together by the CNS of a lot of his works. My neurotology partner, Brad Kesser, here at the University of Virginia. And I say thanks to all the residents at the University of Virginia as well. Over the past 7 years, we've developed a microsurgical anatomy curriculum in which we do these dissections on a monthly basis. And we work together to try to develop slides and have really refined a lot of the presentations for each of these standard skull-based topics over the past decade. I just want to put in another plug. Hopefully by this time next year, we might be looking at COVID in the rearview mirror, or at least have a little bit better handle on that. And certainly much of our planning for the annual meeting has already started. And a lot of, the topics that folks come to these type of lectures for, learning anatomy and learning approaches, and hearing from folks that share their experience and teachings, obviously will be there and in a live format again, we hope. And so would definitely encourage your participation and attendance at that meeting next year, and look forward to that in Austin, Texas in October. So as I said, this retrosigmoid approach, often termed the sort of the workhorse approach for pathology in the posterior fossa. It's sort of an expansive topic, and I think we can go from being too basic to being too advanced. We know that this is a course meant for skull-based fellows and also senior residents, but I wanted to make sure that we sort of go through a lot of the basics that I continue to teach in the operating room and in the anatomy lab, starting from reliably understanding surface anatomy and what is the pertinent surgical anatomy that we're going to be dealing with regards to the retrosigmoid approach and the CP angle. We want to try to get a better understanding of what is the utility of the retrosigmoid approach in clinical practice, so that you can try to select appropriate indications for its use. And then we want to try to systematically come up with a set of steps or skills that we can utilize to better perform this surgery in your own practice. So with that, I think we'll start here. Of course, the first thing that we want to try to understand is all of the pertinent anatomy, but understanding three-dimensional anatomy or looking at an MRI and understanding the pathology that's there doesn't necessarily translate to the operating room. So the first thing we need to try to understand is to get that vision through the skull to understand what is going on and how do we utilize this approach. And of course, all these approaches, the pre-sigmoid approaches that are going to be discussed a little bit later and emphasized next time, including the translabyrinthine and the retrocochlear approach and the transcochlear approach, they're all, and the retrosigmoid approach today, they're all centered around where is the sigmoid sinus. And so that, becomes the first anatomic landmark that we have to visualize in preparation for surgery. In my practice, I use three things other than the preoperative imaging, and the surface landmarks that are easiest to identify to help us sort of dependably understand where the sigmoid sinus and the transverse sinus is I utilize, let's see if I can get the cursor to come up here. I utilize I guess I'll do it on this view here. I utilize the posterior, or the root of the zygoma, the posterior aspect of the zygomatic arch, and then draw a line from there to the asterion. And then I typically go about 1 centimeter or so above the inion to try to get a correct trajectory for where the transverse sinus is going to end up appearing. So typically, so that's the straight line, and I'll show this a little bit later on some cadaveric dissections to show you how we can best approximate these. These are things that when you put the patient in position, they're readily identified landmarks that will hopefully be utilized in conjunction with preoperative imaging to really understand where that transverse sinus is. So this is the course of that, and I want to show a dissection from the Roten Atlas, which I think highlights that very nicely. Here we look at the 3 sutures that come to form the asterion: the parietomastoid suture, the lambdoid suture, and the occipitomastoid suture. Their junction is the asterion. And typically that area you can feel on your own skull or on others as is a relatively flat area in this region, in the mastoid region. And from there, I palpate the root of the zygoma, or the posterior aspect of the zygomatic arch, and then the inion, and we go just above the inion and draw a line there. And as you can see on this image, right here, that for the most part reliably will show you where that transverse sinus is running. One thing to note is that the transverse sinus almost crests right before it turns into the sigmoid sinus, and so the trajectory is actually downward just a little bit as you go medial towards the torculum. So as just keep those anatomic landmarks in mind. Now, of course, we're going to talk about some of the other approaches. I think we are going to discuss the middle fossa craniotomy and middle fossa approach and its indications a little bit more later today. And we're focusing today on the retrosigmoid or suboccipital craniotomy, which is shown in the bottom left image there. And of course, the translabyrinthine. These are the primary approaches that we discuss most often for this region, and especially in discussing how to take care of vestibular schwannomas or acoustic neuromas. And folks often ask, which is the best approach for this tumor, or how do we decide? And I say that, there's 4 major pieces of information that we want to try to assimilate as we try to understand the indication for surgery, number 1, and then also the best surgical approach that we can utilize. I put an asterisk here next to detailed history because I think that history and physical examination, of course, are still very important. We know that vestibular schwannomas, typically the presentation is with unilateral hearing loss. Some patients will have profound vestibulopathy as a presentation and can at least usually identify periods in which vestibulopathy existed, or some types of dizziness or imbalance. Most patients, regardless of the size of the tumor, very rarely have facial weakness. And I think it's of paramount importance to understand the indications and make sure that you exclude some common symptoms that happen with facial nerve tumors that can obviously mimic vestibular schwannomas in this area. I always ask for presence of altered lacrimation, presence of altered taste, as well as the presence of any facial weakness and twitching. All of those things are of key historical importance in making sure that what you assume to be a vestibular schwannoma is not actually a facial schwannoma. It happens very rarely, but it's an important thing to understand preoperatively, and no better time to do that as when you're obtaining the history and physical examination and providing counseling for upcoming surgery. Certainly, it drastically can change operative management paradigms and ought to be taken into consideration. Of course, the audiogram plays a critical role in determining the surgical approach, primarily because two of the approaches that we're looking at here are possible, and we can utilize those. That's the retrosigmoid craniectomy and the middle fossa craniotomy. We can use those middle fossa approaches and retrosigmoid approaches for hearing preservation type operations, whereas the translabyrinthine by necessity is not a hearing preservation surgery, but will result in hearing loss. As MRIs have become more and more high resolution, I think the need for temporal bone CTs per se has diminished, especially with regards to the retrosigmoid approach. Certainly we can visualize where the jugular bulb is and the regional anatomy quite well on a high resolution MRI. So I get the temporal bone CTs less and less as for the retrosigmoid approaches, unless there's some unique anatomy that's there. But I think these are the sort of the minimum things that we should be looking at as we try to evaluate which approach to utilize in approaching not only the CP angle, but quite specifically acoustic neuromas. Of course, we take into consideration hearing status, as we discussed before, but I think position of the tumor, the extent of tumor, how much tumor is in the posterior fossa in general, I try to use that. I use both the translabyrinthine approach and the retrosigmoid approach, and occasionally the middle fossa approach for tumors. And so I really try to tailor it based on the anatomy that's present and what the pathology is and some patient factors in order to determine which approach we are going to use here. When I say position of the tumor, primarily we have some types of vestibular schwannomas that are primarily in the CP angle with very little extent into the internal auditory canal. Those types of tumors, I strongly prefer to utilize the retrosigmoid approach. Of course, if they are small tumors that are localized just to the canal itself, a middle fossa approach might be a better approach to utilize in that situation. Likewise, the presence or absence of a fundal cap of spinal fluid, I believe, is quite important to help us. It helps us intraoperatively also determine when I start the drilling of the IAC, how easy will it be to identify the facial nerve, the cochlear nerve, and a lot of that, especially distally in the internal auditory canal, is determined by the presence of a fundal cap. The position of the jugular bulb and the relative position of the tumor are probably the most important factors. When I have tumors that are quite large, that are hanging below the corridor that's created from a high-riding jugular bulb, I tend to use a retrosigmoid approach. If there's a big corridor between the middle fossa dura and the jugular bulb, then even with medium-sized or large-sized tumors, you can utilize a translabyrinthine approach and have excellent visualization with little to no retraction, obviously, on the cerebellum. Auditory brainstem implants, I see a lot of patients with NF2, and of course, the translabyrinthine approach affords a better trajectory for placement of the auditory brainstem implant. And so that approach is favored in that situation. In those situations, hearing loss is expected. Finally, I think it comes down to also familiarity and ability. There are many institutions in which only one approach is utilized. It really goes to show you that, especially when it comes down to the retrosigmoid and the translabyrinthine approach, in situations where hearing loss is already evident, or if there are tumors that are larger than a centimeter or centimeter and a half, where hearing loss is likely with surgery, that I think a surgeon's ability and familiarity with a certain approach certainly should take high priority in determining which approach is utilized. In general, I think we all try to create a template to utilize, but I've told you what are the sort of input factors that I use to try to determine which approach is best. each of them has its benefits. I think the biggest benefit of the retrosigmoid approach is the panoramic visualization of the CP angle. I love the approach because you can see immediately from the tentorium down to the jugular foramen and the lower cranial nerves with no issues. The biggest issue, of course, is when you drill out the IAC, is making sure that you obliterate any air cells within that temporal bone that you drill, and trying to ensure that you reduce the risk of CSF leak. Especially with larger tumors, it requires some amount of cerebellar retraction, but as you'll see later on, with most medium-sized tumors, and in my practice, even large tumors, I typically do not use any type of fixed retraction system. The translabyrinthine approach, of course, identifies the facial nerve very early on, and it's very nice to understand the trajectory of the facial nerve as it is entering the posterior fossa. And we'll talk a little bit more about that because, in the retrosigmoid approach, you can also cheat and do that portion of the case as well and get that understanding quite early on. But you can do very large tumors with very little retraction that's required with the translabyrinthine approach. Of course, the biggest drawback is for smaller tumors in which you want to try to do hearing preservation surgery. That's mutually exclusive with the translabyrinthine approach. And finally, the middle fossa approach, I'm going to defer to Dr. Mowry. She's going to talk a little bit about that later, but certainly it's the only approach I think that really exposes small tumors and gives you the best chance at preserving hearing, especially when tumors are small and located in the distal internal auditory canal. So, with some understanding of surface anatomy and I think the next question that comes up is we've selected the approach, and now we're going to focus really on the retrosigmoid approach. Next question that comes up is, well, how do I position the patient? What's the best position? Again, what seems to happen is familiarity and ability. When even at the University of Virginia, I have a partner here who has done seated retrosigmoid approaches for past 15 years and does every retrosigmoid approach for acoustic neuromas that way. I trained with him and then developed and sort of adopted the 3/4 prone method that you see over on the right side of the screen. And of course, especially for folks who are doing a lot of translabyrinthine approaches and working with ENT colleagues, I think that fifth nerve tumors and trigeminal neuralgia cases oftentimes are also done in a supine with a roll underneath the shoulder to promote contralateral rotation of the head. And so I think each of these has its benefits. The big thing with the seated approach, of course, is the risk of air embolus. But the biggest benefit that you have with the seated position is that you can use extensive amounts of irrigation. All of the bleeding runs out of the wound itself as you're irrigating, and essentially you can do the surgery with just continuous irrigation and blood loss that is never going to fill your field. As I said, the biggest drawback, of course, is monitoring for air embolus, especially when you're working around large emissary veins and as well as the transverse sigmoid junction. The reason that, and I'll show you the approach that we use, that this 3/4 prone approach, I think the biggest issue with that is how long it takes to position patients comfortably. There are a lot of variations to where you can place the arm. I like to place the arm and have it hanging below the edge of the bed as shown here. The biggest drawback to this approach is that the body habitus of the patient plays a critical role in your ability to have a good working corridor for both of your hands to be able to be effective with the operation. So it may require you to tape that arm down. Even in larger patients, I've been able to do this and get adequate positioning and be able to work in this position. But certainly, in patients with larger body habitus, the sitting position is quite a bit easier for patient comfort as well as for visualization. So in each of these, regardless of the approach that you take, obviously the internal anatomy is the same. And so once we get past how the head and body are configured, I think the surgery itself will be very similar regardless of the approach. So we can utilize some of those videos that I'll show to you in a little bit, regardless of the approach that's taken and the position that's utilized. What's important, regardless of the positioning, is that the cardinal movements of the head are done that expose the mastoid effectively. And so that requires lateral rotation, lateral flexion, and flexion of the head in somewhat of a military position so that you can try to expose the suboccipital region of the bone effectively and increase the distance from the occiput to C1. All of these things elevate the mastoid to the highest point of the operative corridor. And that really, and if you're in the seated position, it puts it most posterior or closest to you so that you can, try to keep the shortest working distance, number one, but also have a clean line of sight for the eventual target, which is, of course, the porous. And so those cardinal movements really try to enable you to get direct visualization of the porous acousticus. Now, one of the major things for retrosigmoid approaches and is also for the supine head turn position is to make sure that the head is above the heart. It promotes venous drainage, keeps venous congestion, especially with larger tumors, to a minimum. If you're fighting cerebellum the entire case, that's usually when we end up having to use any type of fixed retraction, is really when the cerebellum gets full or is congested, and you can obviate a lot of that simply by really extending the head, and that allows you to bring the back or the head of the bed up, which essentially puts the head above the heart. I'll point this out on some of the next set of images as well, but the fixation system and the placement of the fixation system is very important. Always make sure that there are the two pins that you put in. If you put them in the forehead, that's fine. If you put them on the back of the head, make sure that they are on the contralateral side of the Indian, especially in the three-quarter prone position. Otherwise, those pins will get in your way for where your hand should rest as you do the surgery itself. I usually don't use neuronavigation for any of these types of approaches, mostly because the corridor is so small, and I'll discuss that in just a few slides here. You have a panoramic view, but the panoramic view is really provided simply by changing the angle of the microscope. No significant actual movement of the microscope north and south. But it becomes very imperative that you register your brain. And what I mean by registering your brain is that you look diligently at the preoperative imaging, at the CT scan, at the brain MRI, and look at the acoustic neuroma and really try to understand what are the nuances in imaging that I can use intraoperatively to understand where I am during surgery. And you take those into consideration even as early as when you're drilling and you're finding your emissary veins and such. And so we'll talk a little bit more about that as you go on. And of course, we talked about how body habitus also needs to be taken into account. One of the major issues, and I always spend time on checking and double checking positioning, because having the appropriate operative window, and that includes even outside of the patient, is the most important aspect for a successful surgery. So some of the things that we want to really be aware of as we think about things for surgery. The retrosigmoid approach oftentimes we can have a pneumatized, the mastoid is quite pneumatized, but you can, just by studying, even if you don't get a temporal bone CT, if you have a low resolution head CT even, you can see where the mastoid air cells are. So in this patient, for example, you can see that their sigmoid sinus is here, that their mastoid air cells are very far forward. So it's unlikely that you are ever going to see the mastoid air cells in this operation, right? And so I think that just makes it, it's such a benefit to have that understanding before you start the operation rather than doing everything routine in a certain way. Make sure you study the preoperative imaging. You can also pick up on emissary veins that are going from the scalp and going through the bone, and then inserting into, typically the sigmoid sinus will have an emissary vein, and then in the region of the transverse sigmoid junction there will be an emissary vein. These emissary veins are so important to identify, to skeletonize, and cauterize and transect sharply before they enter into the sinus itself. Oftentimes, what we can see if somebody is just drilling a little bit too quickly and sort of barreling their way towards identifying the transverse and sigmoid sinus, you get some bleeding and you just keep waxing this. The problem with just continuously waxing as you get closer and closer is eventually you're not going to be able to wax the sinus, right? And so that's why it's really important when you're doing your drilling, understand where these emissary veins are, skeletonize them, take them out of the channel, and then cauterize them and then transect them right before they enter the sinus. If you take a look here, I put up a video of another patient with neurofibromatosis type 2. So important to look at imaging, not only just in patients with NF2, but also in patients with any type of acoustic neuroma. So much to learn and so much to look at and make sure that you understand before going into surgery. So for example, in this patient, you can see several things. Number one is you can see that there is, they can have multifocal tumors, so you can see enhancement more distally in the internal auditory canal. And you can see also on the left side, so let me get to the right imaging here, you can see also on the left side, this patient has facial weakness as well, and you can see that the stylomastoid foramen has tumor within it. So this patient has a facial nerve tumor in conjunction with a cochleovestibular schwannoma. I say cochleovestibular because in these patients, they usually have dozens of tumors, and the conglomeration of those tumors is what gives them their multilobulated appearance. You have to really study MRIs on patients with NF2 because they have meningiomas that will juxtapose with their vestibular schwannomas. As you can see here, they will have lower cranial nerve schwannomas that will abut the inferior aspect of their vestibular schwannomas. So it becomes very important because these patients really depend on your ability to remove just the vestibular component and leave facial nerve function, even if there's a neuroma, leave it in situ, and also leave fifth nerve tumors in situ so that they don't have multiple cranial neuropathy. So you can see this patient here has a fifth nerve tumor, and that's going to abut. And so instead of seeing a clean fifth nerve on the top, you're going to see another tumor. So you have to know where to stop in these operations, and it only comes from critical analysis of the preoperative imaging that you're going to be able to do that. Of course, tumors, the high resolution imaging that's available now on the it might be called KISS sequence, BFFE, whatever it's called at your institution. It's just absolutely amazing how much we can see now. You can see the lower cranial nerves coming out. What are their relationship to the inferior pole of the tumor? When you take a look even closer, you can see, if you just look at the post-contrast imaging and the standard T1 imaging, you don't see cysts that are associated with the tumors, but it becomes critical to decompress those. And you also understand in this situation that maybe that's getting closer and closer towards the sixth nerve as you do the surgery itself. And so it becomes important for you to know that look at the medial aspect of my cyst, there is the sixth nerve going into Dorello's canal. So, understanding all of this regional anatomy really makes surgery so much more interesting, number one, to understand that anatomy. And it's not a mystery as you go through surgery, what's going to happen next, right? And it's having that vision of what's going to happen next that makes surgery so intriguing in this posterior fossa. And I think why folks who do this surgery just love the surgery, because there's so much anatomy in such a small area that can be so intricate, but it's really interesting and amazing to see. So once we get down into the approach itself, of course, we're going to look at these on some cadaveric dissections and see, but it is another emphasis becomes the trajectory of nerves in these areas. One of my favorite diagrams is this bottom right image here, which is in the Roten Atlas, which shows you that with a very similar located retrosigmoid craniectomy, how you can visualize on the left side of that image the CP angle, how you can modify it and go over the cerebellum just a bit to identify the fifth nerve for trigeminal neuralgia and microvascular decompression, and identification of the superior neurovascular complex, and then also the lower neurovascular complex or lower cranial nerves and pica by just moving the craniectomy just a little bit lower and being able to elevate the cerebellum and identify that. Usually with bigger tumors, it's not uncommon to have all three of those and see cranial nerves 5 through 11 very easily with one of our larger retrosigmoid craniectomies. So, when we take a look, it's always important to understand the trajectory, whether you're operating inside the supratentorial in white matter and you understand where's the corpus callosum versus the centrum semiovalli, what are the trajectory of the fibers that are going on. The trajectory of the fibers are so important inside of the posterior fossa, where they're originating from and where they're going to go, and we'll show that in greater detail. But understanding that the trajectory of the fifth nerve is going diagonally forward and anteriorly, whereas the seventh, eighth nerve complex starting inferiorly in the brainstem and ascending laterally into the internal auditory canal versus the lower cranial nerves. And of course, you can see tucked back here the sixth nerve. The sixth nerve coming at a very sharp angle and entering into and much more medial and entering into Dorello's canal. So simply understanding these trajectories can help you identify nerves during surgery, help you identify their associated neurovascular complexes. And so, of course, associated with the fifth nerve, superior petrosal vein inserting into the superior petrosal sinus. And then we have ICA, a loop of ICA here with the labyrinthine artery coming off of it, associated with the 7-8 nerve complex and associated with hemifacial spasm. And then pica looping around 9, 10, and 11 and geniculate neuralgia. So I think it's very important to understand these sort of trajectories. But again, such a small corridor and angle of change that lets you see the different trajectories. And it's sort of highlighted on the inner view of the temporal bone, how small of a region it is really, and how much an angle, just a 10-degree difference in this area, whether it is achieved by positioning or just angling the microscope, will get you such a better view. So, what I'd like to do next is I have a cadaveric dissection that I wanted to go through step by step, and I will pause at any time. And there's some inset pictures that I've put in here for discussion. If any of the moderators want to interrupt or ask questions or talk about preferences, happy to do that. If anybody chimes in or has any questions, I will be happy to answer those as well. And so we're going to just start. Obviously this is the left ear, and I've left this open so that we can sort of see the positioning. Here is obviously external auditory canal. Root of the zygoma will be just a little bit higher, and we'll mark out some locations in a short bit. The first thing that folks ask are, where do I place the incision? A lot of people say 2 finger breadths behind the ear. It really depends on what the shape of the incision and the retractor that you're going to use is, right? The main point is you want to be able to, feel the mastoid and make sure that you can drill anterior enough to be able to drill the mastoid and be able to see the sigmoid sinus. What you need to understand is, where is the asterion, where is the inion, and where is our root of the zygoma, and map out all of these structures. I always place my incision more anterior because I use a linear type incision or a lazy serpentiginous incision like this. And I put a retractor in that equally moves things forward and backward. And so with that, by doing that, I have to place my incisions just about 1 finger breadth from the back of the ear versus 2 that is commonly used if you use a circular incision. We're going to place the retractor in and go ahead and move forward. Obviously dissecting some of this musculature that is inserting into the nuchal line here. And, very little dissection needs to be carried on down below the nuchal line, right? So here we have our asterion, the confluence of our sutures. And, when we take a look here and you start seeing the slope of the posterior fossa, there's not much surgery that happens down there, especially if we're not targeting lower cranial nerves as the primary surgical approach, or lower cranial nerve schwannomas. Instead, we have to remember that the posterior fossa actually starts right around that level of the asterion. And so most of our surgery is going to be well above this area. So unnecessarily bisecting the muscle too far inferiorly is not needed at all. And so, when we take a look here, we've exposed just a little bit of the suboccipital musculature, and I'm going to go ahead and point out some regional anatomy here again that we're going to talk about. I'm going to place a probe here in just a minute and get to that area. There it is. So we're lining this up just like this dotted line right here. So we're translating where is the zygomatic, posterior root of the zygomatic arch, where is the asterion, and where is about a centimeter above the inion to approximate where the transverse sinus is going to be. And so this is that line right here. And you can see that, overlies that asterion by nature of the landmark there. But it sort of gives us a very good approximation of where we should start our work. I always encourage, a bit of safety when we're thinking about things. When we're talking about where do we start our drilling, I usually say come about 1 centimeter inferior and 1 centimeter posterior to asterion, just to give it a little bit of safe corridor for us to be able to start the craniectomy and ensure that we're going to see posterior fossa dura. And so that's typically where we start right here. Then I want to, as everybody has, no matter how much we use the anatomic landmarks, there's always a question as the residents are drilling this, is where is the transverse sinus? And everybody always says, so that looks blue, that must be the transverse sinus. And almost unequivocally, they're never there. And the reason for that is, I think trying to recognize the blue of the transverse and sigmoid sinus is great, but there's also a few other additional features you can use, I think, which can help you greatly. One is the fact that the cerebellum is convex, right? And so is the dura in that area. And so that's what I'm illustrating here, is there's a sort of a turn that happens right there, and you should be able to see that. you should see that turn of the dura as it is moving into the skull, and you should be able to visualize that and see that that's where the transverse sinus is coming up. Here, you know, we can see that we're entering some mastoid air cells. Of course, we need to be waxing those as we go along, but this is the exact area that I'm speaking of right here. Is you can see that there's a general curve that happens. So this sticks out and starts turning inward. You can also see that there's a change in the consistency of the dura overlying the sinus. And so by doing all of this, we have, you know, we have isolated and sort of shown just the edge of the sigmoid sinus and the edge of the transverse sinus. Again, you know, in this situation, we saw mastoid air cells. In other areas, we won't see mastoid air cells at all. And, you know, we want to make sure we understand where the emissary veins are. You can see an emissary vein here going into that transverse, into the sigmoid sinus. And we just need 1 millimeter or 2 of this area. Make sure that you wax these air cells as you go along. And you can see here, I think that we've done sort of a extensive exposure here just for our anatomic purpose. And you can tell here, this is sort of the inner area of what we have exposed. So moving forward, you know, next is the durotomy and actually opening the dura. I think you can open this in so many different ways. The general principle is just have a little bit of dura that you can use to retract the transverse and sigmoid sinus so that you can have as clean visualization as possible into these CSF corridors. Usually I place some sutures that we can use to retract these things out of the way. Next thing we're going to do is take a look intracranially in the cadaver specimens. You know, I usually take a little bit of the cerebellum more medially so that we can retract a little bit easier. Of course, we don't do that, and I'll show a live surgery video of how easy it is to get relaxation in this area. The first thing we're going to look at as we go inside, of course, is, you know, at that transverse sigmoid junction, we can see the petrosal sinus coming up and inserting into that area at the junction of the petrous bone and the tentorium. And as we go forward, you know, we sort of look a little bit more inferiorly. You can see the bulge of the posterior wall of the internal auditory canal, and you can see the 7-8 nerve complex there. And so what we're looking at right here is the 8th nerve right here, the 7-8 complex going into the internal auditory canal. You can still see a little view of the petrosal sinus right here. And of course, what we're looking at here, and you can immediately appreciate, even though we're not in 3D here, you can see how this 7-8 complex is coming up and forward from its origin, right? And that, I'm just going to go back just for just 1 second, but you can see the trajectory of the 5th nerve going more anterior into Meckel's cave and going anteriorly. And so really want to try to understand and identify these specimens and the direction of these nerves, how different they are as you're dissecting. Same thing as you look inferiorly, you can still see 7-8 nerve complex up north, but you can see 9, 10, and 11 here. So 9, 10, and 11. And you can see that a little bit as we just angled it inferiorly. You can tell that we didn't do any more dissection with regard or exposure in the suboccipital regions, just a 10-degree change in the angle of the microscope, showing you here the jugular bulb as well, and showing jugular foramen in association with those lower cranial nerves. So we'll turn our attention, you know, back to this 7-8 nerve complex. I am showing you where you could find the 6th nerve on this specimen. I couldn't find it too well, but you know, it is possible. So again, you know, the angle, just minor changes in retraction, you know, really give you a panoramic view of all of the lateral brainstem and of the nerves themselves. So I just wanted to show you that with an endoscope. What does that look like with an endoscope? You can see the pristine view with the endoscope here. You know, again, we can see the dandy vein inserting into the petrosal sinus up north. You can see 5th nerve We're going to start here with the lower cranial nerves. You can see 11 coming up from foramen magnum going in. You can see the fibers of 10 and 9. And you can see also the 7-8 nerve complex here. Excuse me. Sorry, you can see the 7-8 nerve complex here and then the 5th nerve there. So going back to the microscope, we're going to go back under the microscope and go up to the next step of the surgery, which is, of course, drilling out the IAC. Here we can see, the typical course of the 7-8 nerve complex. It's going to continue along the trajectory, going just slightly superiorly as it deepens and turns into the temporal bone. Here we're drilling out the IAC, and you saw how the dura was opened and reflected, and then we continue to drill the bone until the dura of the internal auditory canal is exposed. Typically here we like to have about a 180 to 270 degree exposure of the canal. That means that we don't just expose the posterior dura itself, we also want to drill a superior and inferior trough, especially when we're dealing with the tumors itself that are filling the internal auditory canal, to make sure that we can clearly identify where the facial nerve and cochlear nerve are. We have to be a little bit careful, especially in drilling that inferior trough, especially if we have a high riding jugular bulb. Watch for venous bleeding in that area. After the dura is exposed in that area, so here's an image showing what the dura exposed in that area looks like. Not too much of the inferior or superior trough are drilled here. But we can see, opening the dura of the internal auditory canal, of course, then leads to visualization of the nerves themselves. We've drilled out, we've opened the dura, and I resected a little bit of the dura for clearer visualization. You can see we've drilled out the internal auditory canal until we get to the transverse crest here, which is going to delineate the superior vestibular nerve and facial nerve from superior vestibular nerve and the facial nerve from the cochlear nerve and the inferior vestibular nerve. You can see here the same operative corridor of the translab of the retrosig approach that we've done on the cadaver. You can see the transverse crest coming here, splitting these nerves that are going north from the nerves that are going south here. So I've sort of shown that a little bit here as we avulsed cranial, and you can see here this is the transverse crest that's going to divide these lower nerves in the internal auditory canal from the upper. And so here, by doing this maneuver, we have avulsed the inferior vestibular nerve and the cochlear nerve, leaving only the superior vestibular nerve and the facial nerve in the north half of the canal. And then you can see the division there also between superior vestibular nerve and the facial nerve, and I'll go ahead and avulse that superior vestibular nerve, leaving only the facial nerve intact. So, that's the cadaveric dissection. I wanted to just talk, we have a few cases. It's 11:50. We have a few cases that are going to illustrate more anatomic points and surgical points with regards to the retrosigmoid approach. But I wanted to bring in the moderators so that we can go through some cases. I have another long video to go through with regards to the retrosigmoid approach with a live surgery that was recorded, and we'll go through that with one of the cases. So with that, I wanted to include Dr. Mowry and Bamakitis in a discussion of the cases, and I wanted to start with the first case, a 49-year-old female who presented with right-sided tinnitus and hearing loss and 3 months of rather intense facial pain. In looking at the audiogram here, you can see that her speech discrimination score on the right side is 100%, and her recognition threshold is only 20 decibels, and so she has excellent hearing in that ear. I'm going to show you some imaging that she came with, and then I'd like to have a little bit of a discussion about what would be the initial management strategy for this patient. And so here we can see right CP angle tumor. You can see that it looks fairly standard, and for a medium-sized tumor. You can see that there is a knuckle of the tumor clearly indenting the root of the trigeminal nerve on this image, and you can see a cluster of blood vessels sort of sitting at the top of the tumor as well. On the high resolution T2 imaging, we can see again on this image right here a clear indentation of the fifth nerve root. As we come along, we can also appreciate that it has a small cyst associated with it as well. You can also see that fundal cap of CSF in the distal IAC. You know, that's a very helpful finding. You know, if you compare preoperative MRIs in these situations, you can see there's contrast enhancement that goes all the way distal here, you know, all the way out essentially to the cochlear aperture. But on the high resolution T2 sequencing, you can see clearly that the tumor doesn't extend that far. So what causes that? Well, what we've looked at is we know that these vestibular schwannomas, they are secreting not only proteins, but they're also vascular. They're permeable to contrast. And so they leak contrast the longer you wait after installation of dye. So it's not uncommon to exaggerate the size of the tumor or involvement of the IAC. So I always look at the high resolution T2 sequences to see if we can see a clear delineation of the distal nerves. You can see here on the top half of the canal, there is tumor that goes out very lateral, but on the bottom half of the canal, it does not. So that, you know, more likely you can also try to understand whether the tumor is involving superior vestibular nerve or inferior vestibular nerve as well. So my first question, you know, maybe we'll do a Q&A session for management for this real quick. What would your first inclination be, Dr. Bambakidis or Dr. Mowry, in this patient, 49-year-old lady with 3 months of right-sided facial pain and tinnitus? She's tried medical therapy for the facial pain and it doesn't seem to be helping.
Go ahead, Sarah.
Well, first of all, I would say thank you for getting an MRI, right? Like I think a lot of these patients who get diagnosed as trigeminal neuralgia never get an image, and unfortunately sometimes we find these patients who have actually relatively large vestibular schwannomas who have been treated as trigeminal neuralgia patients for a long period of time. I think the fact that she has some other cranial neuropathy, although they're sort of subtle or soft, you know, she has tinnitus, and that's an eighth nerve symptom. So she has multiple cranial neuropathies, and I think so it's good that we got an MRI in the first place, right? So now you can diagnose her. I think the problem that you have with this lady is that unfortunately that tumor is really impacted into the brainstem, and although her hearing is really good, and it's really good because she doesn't have a deeply impacted tumor out distally, that anything you do to take this out it puts you know, the likelihood that you're going to be able to save her serviceable hearing. And when as an ENT, when we're talking about serviceable hearing, we're talking about essentially a hearing or word understanding score above 50%, and a pure tone average above about 70. So that's pretty significant hearing loss, but she could potentially still wear a hearing aid if you could save that. But I think with that knuckle that she's got down into the stem, it's going to be really difficult to save her useful hearing in that ear.
And
yeah, I agree. I think that, no, I was going to say I agree with that assessment. So I think it really depends on how bad her symptoms are and how important her hearing is to her. You might choose to do nothing if her hearing is something that she just does not want to risk. But I would probably err on the side of recommending resection in a person in their 40s with a tumor this size. And I think then at that point, it's kind of dealer's choice a little bit. I think either retrosigmoid or translab would be reasonable. Probably would go retrosigmoid in this because so much of it is in the CPA and really not much is in the IAC from what I can tell, but I think you can do it either way.
I think the other thing, Ashok, that I sometimes see, especially in these patients who look like they don't have a lot of tumor in their IAC, is that when you open their IAC, that it's not an open space. Like it's not normal in that distal IAC. So even though on that Fiesta or KISS sequence, it looks like the nerves are just hanging out in a bath of CSF, they frequently are not. Like there's either arachnoid that's really inflamed, or there is in fact tumor that's there, even though it looks like you may not have a lot of it on the imaging. There is definitely something that's in that fundal fluid cap.
Absolutely, and I think the best analogy we have is loculated CSF. You know, everybody's taken out that tumor where just distal to it you have a trapped CSF which gets thickened arachnoid, and it's very adherent. So it doesn't make it easy, but it is nice to visualize. And you can see, you know, on this image here, there is tumor. It's just lining sort of the bottom half. It's just following the specific nerve, right? And it's a helpful marker. A lot of folks, you know, even if you have smaller tumors, you know, with your middle fossa approaches, you know, it's important to have that. I think that if you're going to have a shot at hearing preservation for, you know, sort of these small to medium tumors, if you don't have that, it makes it very difficult, because then you know that the tumor is abutting the cochlear aperture and makes it very difficult to try to preserve hearing. So, you know, the other question I had for you on this patient was, you know, as Nick had pointed out, it's a real dilemma, because the patient, Dr. Brian Vakitas had mentioned, patient's hearing is intact. And so do you want to sacrifice hearing or not in order to try to remove the tumor? In this patient, essentially her trigeminal neuralgia drove her to seek medical attention, not so much the tinnitus. And in the end, because of her age, we recommended surgery. Without a significant observation period, because she had already tried conservative therapy with multiple agents before embarking on surgery. If she had good pain management, I would probably recommend observation for at least 6 months before, you know, going into surgery. You know, we'll talk about this a little bit later, but, you know, a number of vestibular schwannomas can stay perfectly stable or show very slow growth rate. It's much better to have a patient lose hearing through natural history than it is to wake up after surgery with hearing loss. So, you know, the approach we chose to use was a retrosigmoid approach, you know, and we're taking a look here. You can see, you know, the ear is anterior here, the inion is back here, feet are down this way, and the head and the top of the head is over here. So we're looking at her right ear. I put this inset image for you to sort of get calibrated. And you can see that, you know, Asterion is right in this location. You know, we really just overlying her transverse sinus, and we've gone ahead and done the exposure, done the drilling. You can see she had a small emissary vein here going into the transverse sigmoid junction, which was cauterized and cut. And we've laid a patty here and are going ahead for the surgical approach. The first thing, you know, I wanted to point out is sort of looking at that preoperative imaging. You know, we're letting out a little bit of CSF here. You know, we can use, there's 2 options really. You can, for a lot of surgeries, you can, for these acoustics, one of the things I like to do is utilize a lumbar drain. The reason I like to use the lumbar drain is because I don't use retractors, and it just gives me a complete latitude to take spinal fluid out and decompress the brain and just keep it out of the way so that we don't have to place retractors. It also makes it very easy for me. You know, there's no urgent maneuver or letting out CSF and all that kind of stuff. It's all ready for me. As soon as I enter the posterior fossa, we just march along to the IAC directly. But it's very easy to just lift up the cerebellum and release spinal fluid as well. In this situation, what I wanted to point out first in this approach is, in that retrosigmoid corridor, we're approaching and going in here. It is so critical to understand that these tumors are invested with arachnoid. And so there is, in order to preserve the peel margin of the brainstem and the cerebellum as you go in, it's so important to get that initial arachnoid dissection done properly so that you don't damage cerebellar vessels. The veins that are in the CP angle and along the brainstem are much easier identified if you're able to just retract, do sharp dissection when needed, but a lot of this arachnoid will just simply peel off of the tumor as I'm showing here. So even though there's a cyst there, so even though there's this posterior cyst, we want to make sure, and this will help elucidate that, what is a tumor-related cyst? And you can see here, we're just peeling some of this arachnoid back so that we can clearly identify what's tumor. The inclination will be, here's the cerebellum, let's just go outside and there'll be a nice clean plane, but then you'll be challenged with more and more bleeding. We use sharp dissection when bands start appearing. I think, and after that, we've peeled back that arachnoid to really expose the tumor. I do some stimulation on the back side of the tumor, just making sure there isn't some very rare deviant of a facial nerve, which is, usually never on the posterior side, of course. Cauterize the back half of the capsule, and I do just a little bit of internal debulking. Now, there's a lot of variability in how people approach this right here. Some folks, even before they start the tumor surgery, they will go ahead and drill out the IAC, understand where the facial nerve is, and move forward from there. I like to move forward a bit more and do more tumor surgery first. And then after I've done some moderate control of the size of the tumor, especially if it's a large tumor, this helps me, this helps the cerebellum relax. It makes it so that I can continue to work without a retractor so that I can give the case over to the otologist and leave the corridor open so that they can do their drilling as well. But, just going to talk. Yeah, go ahead.
Oh, I was just going to say, I think it depends on when you feel like having the entire CP angle filled with bone dust. Just kind of depends on when you want to do that.
You have to, I think you have to, right? Like, right, Nick? You gotta bring the bone dust in.
And to be honest with you, the residents, and that I work with, we've done this. They do a lot of the drilling, and and we're doing it carefully. But when I get there, I like to sit for a while and do some work, not just immediately turn it over. And so I like to do some of this operation so that when I come back to sit down and we're doing the final dissection of the facial nerve, that we're not doing some of this easy part of the operation a little bit later. Later is sort of her focused approach to the facial nerve. Internal debulking, I think, is fairly standard. Whether you use Sonopet or CUSA or whatever, some type of ultrasonic aspirator. This tumor happened to be fairly soft but vascular, but we were able to use a suction to do the internal debulking on this case. Typically I like to do the internal debulking rather aggressively on patients without NF2. With NF2 is a completely different story because their tumors are multicentric, and so they're like a cluster of grapes. What you're actually doing is going in and finishing one tumor and then going to the next tumor. And so they can have blood vessels that are coursing through there. And if you don't know where the facial nerve tumor is or where the next nerve tumor is, it gets a little bit hard. I just put up this video here just to sort of show technique of holding the capsule open and doing some gentle internal dissection and suction. You can see the tumor gets a little bit firm in some areas, so it's not sucking in some areas. But after the internal dissection, after the internal removal of tumor, then the capsule becomes a lot more mobile. Oftentimes you can perceive that by just putting the suction on the capsule, on the internal part of the capsule, you'll see the capsule come into the suction a little bit. That tells me that we've sort of reached how much we want as far as the capsule goes. once we get there, then, we really want to make sure that we expose the inferior and superior pole and identify nerves. But one of the things is to maintain that arachnoid dissection. So you can see here, we are looking at, you can see a really large superior petrosal vein here going into the sinus, and, identifying that arachnoid, making sure that we stay underneath it. So I'm just keeping that arachnoid up and pushing the tumor down, small pledget of gel foam. I use gel foam instead of patties because they don't stick, right? You just do a little bit of irrigation and that gel foam will come out quickly. And then you can just fill that space a little bit more with irrigation. That really helps separate the tumor and separate any existing arachnoid in that area. So after we're done with that, then that's usually about the time, if we can do a bit more dissection if we want, really, on the larger tumors, I do a lot more of the tumor going into the cerebellum, and I like to find the facial nerve at the root entry zone. I like to get a nice stimulation proximally, and then I'll turn the case over to the otologist. And so when we turn it over, as you were talking about with the bone dust issue, I usually just put a little bit of Surgisol over the cerebellar hemisphere, and then I place, I just take a glove, I cut it to size, and I lay it over the cerebellum. I put gel foam down by the lower cranial nerves. I put it up near over the cerebellar hemisphere just so that bone dust isn't going everywhere. And then I turn it over to the otologist. And so, I think as we showed on the cadaveric specimen, you can see the incision on the dura there, sort of peeling the dura up and down. After the dura is peeled up and down, you understand the trajectory of the 7-8 nerve complex, and then you're going to commence the drilling and sort of follow that laterally. Then I didn't show the dural opening here, but the dura's been opened now, and you can clearly see where the facial nerve is and how the tumor is being dissected. Pardon, let me catch that back up here. You can see how the tumor is being peeled off of the facial nerve, working from the fundus out to the porus. And, a couple of notations, I'm going to skip forward here, and you see this little vessel right here. We're going to encounter some bleeding in a little bit, and I'll show you something about that. There was a small air cell that we encountered in the drilling. Make sure that you pack that with bone wax. Some folks also augment this area with a little bit of fat. You can use, some type of fibrin sealant or something like that to hold it in place. But all of these things, this is the area where you get the CSF leak from. Unless you really push that bone wax in, massage it into place, make sure those air cells are completely obliterated. And then we will move forward and sort of work on the remainder of the tumor. What I wanted to show a little bit more of is, what do we do with any bleeding on the facial nerve itself? You can see here, we just try some cold irrigation first. Cold irrigation, some people say it causes a little bit of vessel spasm and can help. Others say it makes it bleed more. I found that it really sort of stops a lot of bleeding, whatever type of irrigation you use. You can see that despite that, you still see bleeding. Please don't take a bipolar and cauterize that. Just takes a little pledget of gel foam in that area. It'll stop the bleeding, and then you can move forward with the dissection. In this case, it was a small to medium-sized tumor, and we proceeded with resection, and this was sort of the conclusion of the case right here. The second case I wanted to show is a 13-year-old with headaches. We've been talking about NF2 quite a bit. Patients with NF2 usually present in the second decade of life. This patient presented at age 13 with headaches, facial weakness, ataxia, and hearing loss. So these are his images, and I'm going to scroll through that and sort of talk a little bit about some of the nuances with regards to NF2 and the thoughts that you have to have going into it. But also, you know, we can talk a little bit about the approach for this one. So you can see it, obviously, a giant vestibular schwannoma. You can see a contralateral vestibular tumor. You can see a discrete fifth nerve tumor as well. And you can also see on the contralateral side the presence of lower cranial nerve tumors. But this tumor is so large that it either obliterates or displaces the nerves, or you're not able to visualize the difference. We go into the cervical region, and then you start seeing as well multiple tumors here causing compression extrinsically from the cord, but you also see a tumor inside of the cord as well. You can see those a little bit better here. He's got hydrocephalus as well. We can talk a little bit about whether or not how we would manage that in this situation. And you can see the tumor extending well below the jugular bulb in this situation, all the way from tent to the foramen magnum. And then we have this other concurrent tumor here. You can see ventral to the spinal cord. You can see ventral to the spinal cord. That rather large collection of tumors down to the level of C3. So, Dr. Bambakidis and Mowry, what are your thoughts about, I think universally everybody would pick the retrosigmoid approach, is my suspicion.
Yeah, I mean, I think you got to deal with that giant tumor to some degree and do what you can with it. And, you know, assuming that goes well, and that's not a simple assumption to make, you can address probably the spinal tumors next. But yeah, I think a retrosigmoid approach is reasonable. You know, sometimes it's helpful just to do an angiogram on these folks and just get a sense of how vascular the tumor is, because some of them can be very difficult to deal with. And so I kind of like to know that going in.
So which side was his face weak on?
I'm sorry?
Which side was his face weak on? The ipsilateral side to this big tumor, or the other side?
It was ipsilateral.
Okay.
Yeah.
Goodness, I mean.
I'm sorry, go ahead.
I just said, thank goodness, right? Like this is I mean, clearly it's a devastating disease, and he's in a bad place, but I think, you know, I think counseling is probably the biggest thing that, in addition, I mean, like you need to save this kid's life, right? He's got obstructive hydrocephalus, he's got a spinal cord issue, but I think having a frank discussion with the family. I think the other thing that's reasonable to think about in these patients is to look at Avastin, especially in these young ones who have rapidly growing tumors. Avastin is not an unreasonable thing to think about.
It's a good
Yeah,
point.
so,
And I think the facial nerve function for a case like this is, I mean, I think it's going to be real difficult to get a good resection and come out with, you know, a functioning facial nerve when a tumor gets this big.
Well,
And the other thing with the hydrocephalus, I might consider shunting him up front to temporize him, especially if you're thinking about Avastin. It might be the first thing to do.
So what we elected to do was, you know, I did an external ventricular drain, and I spoke to the family about obviously doing retrosigmoid approach for this surgery, and then I said, depending on how that goes, number one, and where we were, I did you know, sort of a extension of the far lateral. So I just extended the incision a little bit further and ended up doing hemilaminectomies at 1 and 2, and also removed all of the intraspinal portions of this tumor as well. And, one of the issues that I wanted to bring up is, patients with NF2, you're not curing the patient by removing all of the tumor. So here's an example of what we found in the majority of patients with NF2. You always see this multilobulated tumor that's on the right side. You can see the deep intratumoral clefts that are there. Have to be very careful about, number one, vessels going through those clefts. And so there's a higher incidence of distal ICA infarcts because small blood vessels are sort of trapped in that area that go on to further feed the peduncle. The second issue that you have to be careful about is the presence of coexisting tumors. So you can clearly see the image on the left screen here is a patient with NF2, a young patient. So when I was at the NIH, we would scan patients. We were allowed to start scanning patients at the age of 8. So this is a young boy with NF2 who we started scanning at the age of 8. And the concept of hearing preservation surgery or early proactive surgery, this is the challenge that we have, is that it's a biologic disease, right? It's not just one solitary tumor that we can remove. And if you get through that and take a 50% risk and have hearing, at least it'll be good forever. In these patients, their tumors are multilobulated because they're multicentric. And so you can see here, this patient on that example on the left image here with the multiple arrows, has a cochlear schwannoma, has facial nerve schwannoma, has superior and inferior vestibular nerve tumors. And so I think that's the majority of patients with NF2 rather than, the rare example. And so, we just have to be a little bit wary about what our goals are with surgery. And make sure that you have adequate monitoring. Remember that first case that I showed you about the aggressive internal debulking. If you do aggressive internal debulking in patients with NF2, especially if you start sensing that you're going from one lobule of tumor to the next lobule, it behooves you to check the stimulation again. Even facial nerve tumors, if they're quite large, you're not going to stimulate well with them, but it certainly would obviate the mysterious facial nerve loss that sometimes happens. And so, what did we end up doing for this gentleman? We resected the posterior fossa, extended the tumor. And so I had to make a decision between should we drill out the IAC or try to address, which typically adds several hours, right? Or do we try to address the significant compression of his cervical cord as well? And so I elected to go ahead and proceed and do the multi-level laminectomy and remove all the intraspinal portion of tumor there. He actually, as you said, we were able to preserve the facial nerve in his case, but he woke up with significant weakness, right? And you can see on this image here, sort of a little bit of facial nerve thickening right here, and he woke up with grade 4-5 weakness, and 6 months after surgery, it was at grade 3. But, still that gives him a better outcome with residual tumor, of course. But, about 50 or 60% of patients with small vestibular schwannomas that have them completely resected in patients with NF2 done at the Hauser Institute on a 10-year longitudinal study showed that over half of them had recurrence of tumor. And so I think especially in this,
you can't cure their genome with a knife. That's
yeah.
So you just try to preserve function as long as you can for these people. I think that's really the key. And this is a young kid, and so you do what you can to preserve as much function as you can. And you did a great job being able to spare any facial function on that side. I mean, that's a massive tumor.
Yeah, so, but the thing with these tumors in the young folks, they tend to grow when they're really large. I find that, the tumor's much softer, right? And they tend to just behave a lot better. And sometimes the facial nerve dissection can actually go, in the several cases that I've had with NF2 patients with giant tumors, they tend to actually go better than sometimes the sporadic tumors that grow so slowly over time,
Yeah.
But
I don't know, the last couple we've had NF2 patients, their tumors were vascular yucky disasters, which Dr. Biambakides can attest to because he was the one who had to deal with the yucky bleeding
I was going to
disaster.
say, you didn't have to deal with it, so.
yeah, so but what
cool.
you pointed out was right. From the get-go was the ultimate statement is, what is his life now? So later we went on, removed the intramedullary ependymoma over all those levels, and but now it is hopefully treatment with Avastin, and now there's brigatinib, and so I think there's a lot of hope for these patients, and we just have to weigh multiple cranial neuropathies are doing too much when there are some medical treatments that may help as well.
Right.
I have a couple of more, but a little bit quicker cases, I think, and then we'll turn over to the middle fossa and go through your cases as well. First one, I just wanted to highlight, I think, a very specific point. So I had a 50-year-old gentleman. He has some hearing loss. You can see that on the audiogram. It's not severe, right? As you pointed out, he has very serviceable hearing. You used 70%, he has 72%, and has 20 decibel sensory reception threshold, and has some mild dizziness. And he came to see me with this tumor. And I don't want to belabor the point because I'd like to turn it over to you to talk a little bit more about middle fossa. So I'm just going to go ahead and go through it. What would you all do real quick? First step for him.
Well, I'd probably watch it.
Yeah, so I think that's all I wanted to say, right?
Yeah.
Is there's so much information, mostly from the otology side of things about the natural history of acoustic neuromas. There is a population of patients, especially the older you get, over age 70 especially, watch the tumor for a minimum of 6 months and repeat the MRI in 6 months. You can always assume the risk and later, but you can't obviously undo hearing loss. In my hands, typically at this size, I'm going to lose hearing if I do the surgery, with a retrosig approach. And so, this is him 1.5 years later, right? If anything, I don't know, probably not, but his tumor looks the same size as it did originally, and he's the happiest you can be, right? Next case is a 65-year-old with tinnitus, hearing loss, and imbalance. I don't think we have to belabor the point of, the surgery itself. All I wanted to say is sometimes it's very easy to know what to do. And, if you have a lot of posterior fossa volume of tumor with 2/3 of the dissection completed, it's obvious that, the approach can be done and done a lot easier via the retrosigmoid approach. Now, Sarah, you had said something about, it's not that easy sometimes as it seems. Well, this guy had a distal IAC fundal cap that was obvious on imaging. We didn't even get to the point where the otologist drilled his ear because the tumor fell out of his internal auditory canal.
Yeah.
So it was, sometimes I think it is helpful just to, make sure you do the obvious sometimes,
Yeah, sure. I think the other thing about these cystic ones with these big cystic components is that cyst wall is tumor. It's not arachnoid. So you do have to still be very careful about how you're dissecting that cyst wall because the facial can be wrapped up in it. It's sometimes not a discrete nerve bundle at that point. So if you're going to end up leaving part of that cyst wall, because sometimes they are hard to get out, that you have to be thoughtful about monitoring those patients because the cystic ones can be challenging.
Yeah, that first case that I showed was a tumor cyst wall, and I agree with you. The ones that and I had mentioned that it was a vascular tumor. I always find that the ones with cysts are more vascular, number one, and then number two, they're more sticky. The facial nerve gets stretched over them. The reason they form cysts, I believe, is the same that they form cysts in all conditions of the brain, because vascular leak, right? And so the vascular leak happens in vascular tumors. And And I agree with you. Maintaining that arachnoid dissection is of such great importance. I'm going to turn it over to you now.
Great.
Or I think you just usurp control. And
let's see here. Okay. Myself in the right mode here. Can you guys see my screen? Yeah. Okay.
Yep.
Great.
Yep.
Well, thanks. That was. I think that's a the RetroStig is certainly a workhorse approach. You can use it for a ton of stuff. In our practice, we use it quite a bit. I think one of the things I wanted to just talk about briefly is the middle fossa approach. It's certainly not as commonly used for acoustic schwannoma or acoustic neuromas as some other approaches are, but I do think that there's some things to talk about when you're working with a neurotologist who would be doing this approach for you. The tumor dissection, there's some nuance to that is important when you're trying to do a hearing sparing approach. Like I mentioned, middle fossa has lots of uses from a neurotology standpoint. We use it for facial nerve lesions, CSF leak and encephalocele repair. Approaches to the anterior petrous apex, especially in patients who have very small mastoid cavities where, as you saw on some of those CT scans, those corridors can be narrow and hard to get through. Epidermoids or cholesteatoma up in the petrous apex, this is not an unreasonable approach for that. Cholesterol granulomas and the repair of the superior canal dehiscence syndrome. There are, as we mentioned earlier, some advantages and disadvantages to every approach. It gives you really a good opportunity to preserve hearing in patients who have serviceable hearing at the time of surgery. You get wide exposure to the middle fossa floor, and will give you reasonable exposure to the petrous apex if you need to get up into Kawasi's triangle, and we'll talk a little bit about that at the very end. Certainly, there are disadvantages to this approach. You really can't do anything that extends significantly into the CP angle through this approach unless you're going to divide the tentorium. The surface anatomy of the middle fossa floor is relatively devoid of landmarks, and so and it's a little bit of a minefield in there. So if you are doing this operation, it's helpful to understand the orientation of the critical structures that we're talking about here, because there's not a lot of tolerance out at the end of the internal auditory canal. So, and then of course, we're going to retract the temporal lobe, which has its own set of risks associated with it. So in our practice, we generally offer the middle fossa approach to patients who are younger. So these are people who are less than 65, have small tumors and good hearing, and are motivated. And I think that's one of the key points here, right, is that for most patients will elect to observe a tumor, but there is certainly this subgroup of patients who will say, no, I don't want that thing in my head. I want you to try to save my hearing and take it out. As we discussed already, hearing status is also a prognostic factor in addition to having a fundal fluid cap and those kinds of things. So the better a patient's hearing is that you start with, the more likely you are to be able to hear it. So cochleas that are damaged are more prone to have significant hearing loss at the end of the operation. Very small tumors have the best hearing outcomes. Also, additionally, if the tumor comes off of the superior vestibular nerve, it's sort of sitting right there, staring you in the face as you open the top of the IAC, and it's easier to get it out. We also monitor hearing while we're doing these operations, and so when you have a relatively normal or good-looking baseline ABR, which we can monitor during the operation, that is generally more likely that you're going to be able to save hearing in that ear. So as we're approaching these tumors, that you can approach it through a couple of different incisions, but essentially you want to get down to where you can do a relatively small squamous temporal craniotomy. I generally ask so certainly we're monitoring the facial nerve when we're doing this operation, so no muscle relaxants, I do ask them to give Decadron to help with swelling. I usually Ansef and Banco. I do not put patients in pins. I hate pins. I'm an ear, nose, and throat doctor. I hate pins. So we don't generally pin our MCF patients or our translab patients. But Dr. Bambakitis likes pins for retrosig, so I humor him. But because it's mostly his approach.
It just depends on who gets there first.
Right,
here.
exactly. Yeah. So we're also going to set up the ABR and design your incision. The craniotomy for this is a pretty small craniotomy. It doesn't have to be that big. Somewhere between 4 by 4 centimeters or 5 by 5 centimeters. The position of the craniotomy is quite important though, because you want to make sure that you are anterior enough that you can dissect out the IAC. So generally I'm positioning the craniotomy about 2/3 of it in front of the root of the zygoma, or centered on the root of the zygoma, or 2/3 in front of the top of the EAC. So you don't want to expose the external auditory canal, by the way, when you're doing this approach, but you can sometimes feel it. I think the root of the zygoma is a easier place to palpate when you're in this area, so I think it's easier to position your craniotomy based on that. I do generally give mannitol and have them hyperventilate. Lumbar drain, we do sort of plus minus. Not everybody gets one, but it is helpful to have the patient decompressed, as you mentioned earlier, when you're going to start to elevate the dura in these cases. So we'll just run a couple seconds here of this, but this is a lady we did recently with a middle fossa approach. I harvest fascia at the beginning of the case, and then we're going to use that at the end of the case to help us close our defect. I pull the muscle down, and then to help guide my neurosurgical colleague where I want my craniotomy to go, I usually will mark it out with a bovie on the surface of the skull. And then we usually use the foot plate and a B1 to cut out the bone. All right. Next slide. Nope. All right. So now once you get the craniotomy open, this is sort of what we're thinking about and where we need to do. This would be a facial nerve tumor, but we're also thinking about this area here. Can you see my cursor, by the way?
Yeah, I can see yours.
You can. Okay, perfect. So we're going to try to get you down to this place here where you can start to remove tumor. So elevating the dura, the general rule on the middle fossa floor is to elevate from posterior to anterior. And the reason that we do that is that the geniculate ganglion, or the highest point of the facial nerve, is dehiscent into the middle fossa floor about 10 to 15% of the time. And so it is possible to avulse the geniculate if you are just going from lateral to medial and not elevating it in that plane. The limits of our dissection are going to be the sigmoid sinus. Posteriorly, anteriorly, it's going to be the middle meningeal artery and the foramen spinosum. And I really apologize if you can hear that like drilling noise, which is happening on the wall in the room next door to me. Hopefully they won't take too long. Medially, we have the petrous ridge, and we're going to find the superior petrosal sinus along there as well. So the middle fossa retractor that the neurotologists use the most is something called the House Urban retractor. I hate this retractor, but it is what we have in this area. I always called it the fellow torture device. Now I call it the attending torture device because I'm the one who puts it in. So, but it's a sliding stage. This thing slides in and out, and it has like 2 degrees of freedom. If it had 1 more degree of freedom, it would be a lot better. But many times what you want to do is you want to lock it into the petrous ridge, which is running in this direction, but this thing is flat. And so you kind of have to get it in and just wedge it down along the edge of the bone there as best you can. But that's what we use to elevate the posterior fossa, or excuse me, the middle fossa dura. And then these are some key thoughts as we're thinking about the middle fossa floor. The anatomy here is is very flat. There's not a lot of surface landmarks. The two that you have available to you as you're elevating the dura up would be the what's called the arcuate eminence, which is that little knob of bone that sort of pokes up into the temporal lobe. It is, in many patients, does represent the highest point in the otic capsule, or the superior, where the superior semicircular canal comes up, but that is not 100%. So it is not a reliable marker for the superior semicircular canal. But the superior semicircular canal is incredibly reliable in terms of its orientation with regard to the petrous ridge. So it is always 90 degrees to the petrous ridge. When we're thinking about how we're going to find the internal auditory canal, we're going to think about the angle between the internal auditory canal and the superior semicircular canal. So you can see in this like sort of ghosted image, and I have some more images here coming up, but in this ghosted image, we're thinking about this angle between the superior semicircular canal, which is here, if this is the petrous ridge, and the internal auditory canal here, which is about a 60-degree angle or so. Generally, we're working from lateral to medial. Once we have exposed the floor of the canal here, and we're going to work from, oh, that's wrong. We should be working from medial to lateral, sorry. That's my dyslexia happening. And we're going to leave a strut of bone here at the porus acousticus to help lock this retractor in. That's just another schematic drawing of what it is that we're trying to do. As we get out towards the distal end of the internal auditory canal, there's a discrete bony separation, and this is the vertical crest or Bill's bar, where you're going to have the superior vestibular nerve wrapping posteriorly or heading posterior, and then the facial nerve. And this is the opening of the fallopian canal at the what we call the meatal foramen, where the facial nerve goes into the labyrinthine segment. This comes literally like pretty much vertical right there. So it's coming like straight out at you, and it can be very difficult to see it straight on because it is in the plane of your vision. So that's just something to keep aware of. That labyrinthine segment can be tricky to see. So the facial nerve is a little bit tricky in this area, but you can see this is a drilled out middle fossa floor. And so here's middle ear is up here. This is the geniculate ganglion here, labyrinthine segment, geniculate, tympanic segment, and then the greater superficial petrosal nerve, or the GSPN, is tracking then anteriorly and medially along the middle fossa floor. And that is your other surface landmark in this area, because it does come out and come up to the surface of the bone, and you can follow it forwards and backwards to help you orient yourself. This is, I sincerely hope that your middle fossa floor does not look like this at the end of the operation, because the patient will definitely have no hearing. But this is a nice anatomic drill out of what you're going to see, or the structures and how they're oriented in the middle fossa floor. And I want to highlight this incredibly tight connection between the labyrinthine segment of the facial nerve and the cochlea. So there is less than 1 millimeter of space here. And so the tolerances out at the distal end of the IAC are very, very small. So as we're drilling out the roof of the internal auditory canal for you guys, this bone becomes very, very tight to the facial nerve. And that becomes problematic if you have a tumor that is really impacted out at the end of the IAC. Additionally, and as you can see with the horizontal crest down here, if you have a tumor, an inferior nerve tumor, and you have a big crest, it's going to be hard to get that tumor out easily, especially if it's a very distal inferior nerve tumor. So that's another place where the imaging can be helpful to sort of show you where that nerve is originating from. All right, next slide. Oh, so some enterprising fellow, I think it was Bill Slattery at some point, went and measured all of these things. So if you are number-oriented person, These are the measurements in millimeters that are on average found within the temporal bone from the middle fossa direction. All right. Okay. So this is the start, essentially, of a drill out. This is a still picture from middle fossa exposure, but you can see what we've identified here is the superior semicircular canal, and this is a very reliable landmark, and it is the first landmark that we find once we start drilling. The greater superficial petrosal nerve, which is here, is the other very reliable and only surface landmark that you have. So there are a couple of ways that you can identify the internal auditory canal. Some surgeons identify the geniculate and the labyrinthine segment laterally and then follow it back. I personally prefer to identify it medial and then follow it out. But we're going to drill just like any other acoustic approach. We're going to try to drill out the internal auditory canal about 270 degrees. But in this particular approach, we're drilling it out and exposing, or we're leaving basically the floor of the internal auditory canal, whereas with the retrosig and the translab, we're leaving the anterior wall of the internal auditory canal in place. All right, so I mentioned that we sort of think about angles when we're trying to find the internal auditory canal. And as I mentioned, this is a very reliable angle between the superior semicircular canal and the petrosal ridge. Between the superior semicircular canal and the greater superficial petrosal nerve is also pretty reliably about 120 degrees. It's rare that it's different than that. And then the internal auditory canal is going to bisect that angle at about 60 degrees from the superior canal. So if you identify and can blue line the membranous labyrinth, or the actual inner ear, that will be able, you can find your internal auditory canal from there. So this is really the place that at least I started drilling, is to find the superior canal, and then you can find the backside of the internal auditory canal and drill out your posterior trough. And I drill it all the way down to the posterior fossa dura. Many times I'll go ahead and release CSF from the cistern. In this area, it helps to decompress the brain. And sometimes you can get that horrible retractor out at that point and just continue your drilling without a retractor, because the brain is really relaxed at that point. Anterior trough bounded by the internal auditory canal, the dura along the posterior fossa plate, and then anteriorly and superiorly, or excuse me, immediately, you have the cochlea. And so the cochlea is up here, and that's going to be the limit of your dissection as you get lateral on the internal auditory canal. The distal IAC dissection is the sort of the trickiest part of this operation. And the key is, as you're drilling it out, to stay on top of the internal auditory canal. So as you can see in this image, we have a small right angle pick, and I'll show you in a video that we have here in just a second about how you use that pick to sort of figure out where your cochlea is so that you stay out of it. So this is a drilled out IAC, and what you'll see here is, again, this is in 2 dimensions, but you can see that the labyrinthine segment really is coming up at you in this image, with the geniculate being here, greater superficial petrosal over here, and Bill's bar, which is that little bar of bone between the superior vestibular nerve and the facial nerve. And that's the place at which we identify the facial nerve. It's highly reliable in terms of its orientation to find the facial nerve. And then you can map it out within the internal auditory canal and around your tumor. Okay. So this is a middle fossa that we did for tumor, I don't know, a few months ago. I'm finding exposing the middle fossa floor, finding the petrous ridge, getting that retractor, and the place where you lock that retractor in is if there's like this little ridge along the petrous ridge where the right above the porus acousticus, and that's a place where you can pretty easily lock your retractor in, and then it will stay put there. So now the next component is to find the otic capsule, which is that sort of yellower, darker, very solid bone. And use so much irrigation that nobody can see what you're doing. All right, so the internal auditory canal here at the porus acousticus is the place where I usually start my dissection. So we found the internal auditory canal, it's right here, released a little CSF, and now I'm going to start to drill my posterior trough between the superior semicircular canal and the backside of the internal auditory canal. And then move, I do the distal IAC dissection always last. I'll always drill my anterior and posterior trough first. And then I use, again, this little right angle pick to pull the bone off of the dura. And try to get as much of that bone out of there as possible, because it really facilitates tumor removal, especially distally. But you can see that what I'm feeling for there is the distal end of the IAC on the posterior side, and there was more bone to drill there. So on the anterior side, as I move it up, I can drill bone away until I start to not be able to put my pick in very far anymore. So right there is the cochlea. So I can't drill any farther there because I will get into the cochlea. And it drops off relatively quickly. So there's still a bit of bone that can be removed, like inferior, anterior there. But as you get out distally, that's it. That's the end of the IAC there. So that's the cochlea, and you can't really drill any farther than that. And that's the superior vestibular nerve that I was just touching. And then we're going to identify that positively with the facial nerve monitoring apparatus, whichever company you like to use. And then Dr. Bambakidis is going to come in, do some fancy tumor work. Some of these tumors, even when they're small, can be quite sticky and vascular. This was a pretty sticky one, and took a few extra minutes to safely get it off the facial nerve and pull it up away from the cochlear, which you can't see usually until you get the tumor out, that you can't see the cochlear nerve in this approach, even though you're trying to save it. So I think one of the things that is important as you're trying to pull these tumors out is the direction and the vector at which you're rolling the tumor. So sometimes it will roll out the way that was done in this case, but other times you need to roll it from medial to lateral so that you're not pulling on those cochlear nerve fibers, because they are quite delicate. And this is just the repair of that floor to sort of put the cork in the bottle and keep the CSF from getting out. All right. No. So just quickly about intraoperative nerve monitoring. We have a great nerve monitoring group here who are quite savvy and good at monitoring the ABR for us. This is a far field ABR, which means that we're putting sound at the opening of the external auditory canal, and we're using the mechanism of the hearing apparatus and then recording an ABR. There are, or at least there were, direct nerve monitoring electrodes that are no longer being manufactured, although I do know a few people who essentially make their own and do direct nerve monitoring in the operating room of the cochlear action potential. But we've had good success using far field ABR with our monitoring here. This is what we're monitoring, these squiggly lines. So this is the wave 1, 3, and 5 are the sort of waves that we think about on ABR. Wave 3 usually disappears first, and so we ask them to watch that. We also look at the latencies of these waveforms. Latency usually increases before amplitude will drop, and an amplitude drop does usually predict loss of hearing. So I think when we're thinking
real quickly, Sarah, for the ABRs, the
Part of
Yeah.
the problem, can you hear me okay?
Mhm.
Yeah, part of the problem is that often whatever moves you're doing to the tumor, there's such a delay in what you see on the ABR.
Right.
You know, doesn't help you much because you've already done what you're doing to get the tumor out. So I don't know, Ashok, do you use them routinely? And do you find them helpful in all cases?
Yeah, I think, yeah, unless you are exceedingly patient, there's a significant lag because they have to average significantly, right, in order to be able to give you any information about how much has changed. But I agree with you. But that's a lot about monitoring, right? Isn't it? Like that's the issue with monitoring everywhere is it tells you what has happened, not what will happen. And I think we have to be, that's where understanding the anatomy certainly helps, But I agree with you 100%.
I'll try and be more patient then. Sorry, Sarah, go ahead.
No problem, Nick. So I think, even in the most skilled hands, there are still patients that lose their hearing, even when you have a great dissection and the tumor comes out cleanly, you can still lose hearing. And so I think it's important to understand why that happens. So nerve traction is a technical failure and certainly can happen as you're pulling that tumor up off of the cochlear nerve. As those fibers go into the modilus, you're looking at essentially individual neurons or very small bundles of neurons, and so it's hard to not cause shearing injury there. Certainly, another technical problem is if you drill into your ampulla, into the labyrinth or into the cochlea, is going to cause them to lose hearing. Vascular injuries also, I think, probably the most likely or the most common cause of failure. As you know, the labyrinthine artery is an end artery. It also happens to supply the tumor. And so if you are having to cauterize, which most of the time you don't in these very small ones, sometimes they'll just roll out, but you do need to be thoughtful about what it is that you're cauterizing if you're trying to save hearing. Because you may be getting the entire labyrinthine artery or cause damage to the artery that causes the patient to lose hearing. I just wanted to mention another way that we use the middle fossa approach, and that's to drill out that anterior trough a little bit more into Kawasi's triangle. So this is the triangle, or I should say parallelogram, of bone between the anterior internal auditory canal from here, so from C to B, the petrous ridge, and the gasserian ganglion. The greater superficial petrosal nerve in this area will be your surface landmark for the horizontal portion of the petrous carotid. So you don't really want to drill out there too much if you can avoid it. But reasons that you might want to think about using this particular approach: it's a relatively narrow window, but it can get you access in patients who have basilar tip aneurysms that you can't get endovascularly. It can give you access to the anterior CP angle and the prepontine cistern. And then if you have a lesion in the petrous apex, that would be another reason that you might want to think about using that approach and drill out. It does require a much larger craniotomy and to elevate the temporal lobe adequately in this area to get that drilled out. Okay, so with that, I am done talking about middle fossa. So I will stop. And I really should say that this is very much a team sport, and we have an amazing group of surgeons in our skull-based team, as well as our coordinator and our house staff who take care of these patients for us afterwards, our audiology team, our nurses and OR staff, and all of the others who I know I'm missing on this list, but we really can't do what we do without them. So.
Great, thanks, Sarah.
Sure.
So with that, I think we'll spend the last half hour or so, maybe a bit less, just going over some cases that I think highlight some of the key components that we've been talking about today. Let me figure out how to share my screen here.
Sarah, while we're doing that, can I ask a couple of questions?
Sure.
You know, one of the questions I had was, you've identified a facial nerve tumor, and
Yes.
the patient starts to have some facial nerve weakness. Do you use the middle fossa for decompression of the canal at all, and
Yes.
don't even? Okay.
Yeah, I think so. You know, the thing about facial nerve tumors is that they're so different than the other one because they have this very much are multifocal tumors most of the time. So we often will see lesions, multiple lesions along the course of the facial nerve. So you may see some enhancement in the descending segment in the mastoid, and then you'll have some enhancement at the geniculate or even in the internal auditory canal. So I think imaging is the key on those ones. So sometimes you'll have to do like a total facial nerve decompression and do a mastoid component as well. The middle fossa works very well though. And I think for facial nerve tumors, again, and this is a little bit controversial in our field also. So some people advocate, you know, wait until the nerve is out and then you go in and you resect it and graft it. But those patients never do well, you know, like they always have asymmetry and weakness. There are others who advocate maybe you should go in and like resect it when they first start to get weak. So not before they're completely out, because there is potentially better neural targets for that graft. I think the sort of safe thing to do for a lot of these patients though is to buy them time. And so much like, you know, the NF2 is to preserve function as long as possible. And so many times what I use the middle fossa for in these cases is to decompress. So I'll go in, we just take all that bone away and we drill out the labyrinthine segment and we'll drill out the geniculate and open it down into the middle ear and just give the tumor a place to grow into so that they don't get compressive injuries to their nerve.
Do you open the dura as well?
Yes. Yeah, I think you kind of have to because otherwise it doesn't make sense, right?
Yeah. No. And you do the same thing, you know, in some NF2 patients.
Mm-hmm.
You know, because it is about, you know, sort of deferred risk, you know, you can also use middle fossa decompression for hearing preservation. And I think the House group showed at least it, compared to natural history, it may prolong hearing loss for a couple of years, you know. So I think that's very useful use of the middle fossa approach as well.
Great. So we'll just go into a few cases. Here's a case illustrating some of what we've been discussing. 62-year-old man with mild tinnitus, severely dizzy. He has minimal hearing loss on the audiogram. I don't have it to show here, but really could hear quite well, which is a neurosurgical hearing evaluation right there. So
it's
maybe
like you can hear this.
Yeah, exactly. So maybe Ashok, you want to tell me what you'd be thinking at UVA for a patient like this?
Yeah, I think the you know, biggest issue obviously is the disequilibrium, right? I mean, you can obviously offer observation. If the disequilibrium is the biggest problem, then the only thing that's going to make it better is transection of the nerve, right, of the vestibular nerve. And you know, with it, it's I guess still there's no component within the posterior fossa still very amenable to a middle fossa approach, although it is filling the canal. That makes it a little bit difficult, you know, I think. So middle fossa retrosig is certainly an option as well, but you know, getting out that far lateral and maintaining cochlear function is a little bit difficult as well. So I think either one, but it sounds like in these patients who have the severe disequilibrium, they're never happy unless you do surgery, unless you go and cut the vestibular nerve. You know, you can do whatever you want. You can hope that it, you know, compensates and gets better. You know, I just find that surgery is inevitable. for the.
Yeah, I totally agree with you. And, I think you can try vestibular rehab and other things, but you're right. In our experience, cutting that nerve really improves patients significantly. Sarah, what do you think about a middle fossa for this?
Yeah, definitely. I think the one thing I'll say about disequilibrium is that, so I would query this patient really hard about any possible migrainous symptom. So migrainous vertigo is a huge component of the neurologist practice. So we see patients for dizziness all the time. Sometimes we find them, we find that they have a vestibular schwannoma, but if they have other symptoms associated with vestibular migraine or atypical migraine, I think those patients need to be treated as migraine patients and make sure that you're not missing a migrainous component, because if you operate on somebody who has migraine and you cut their balance nerve and take this tumor out, they're still going to be dizzy and they're going to hate you. So I think, and certainly, so I would encourage you to make sure that you're not missing another, because migraine is so common even in a 62-year-old man. I mean, we certainly see that. So I think that's something that I would just encourage people to ask about.
Yeah, no, that's a great point. Yeah, I think middle fossa is very reasonable here for the reason Ashok mentioned. Also, because it's a left temporal, a little less excited about that, retracting the dominant temporal lobe. We've seen occasional rare complications from that. And the fact he's got a lot of atrophy in the posterior fossa, we thought a retrosigmoid approach would be a little bit easier. So that's what we ended up doing. I did this with Dr. Rivas, one of our new partners who joined us from Vanderbilt. You can see the positioning there. We tend to do these supine and not do them in a lateral position, but as Ashok pointed out, really there's really, it's dealer's choice with that respect. You can see here the opening that is very similar to what we've shown earlier with the sinuses, drawn with a marking pen, just sort of to give a visual guide for drilling. And then you can see here, we use lumbar drains pretty commonly as well, just to make things a little easier. Certainly don't have to do that. You can see the lower cranial nerves, see Dandy's vein, fifth nerve, and then the seventh and eighth nerves. You can see here, you're just barely seeing a little bit of tumor.
So where's the tumor?
Yeah, well, you're barely seeing it.
Yeah.
The one view previously. This is a retractor in place, and I just can't get the ENT people to not stick those in sometimes while they're drilling intradurally. But you can see there now opening the dura a little bit, continuing to drill. And now you can really see where the tumor is within the canal and opening the dura. We tend to use the stimulators, the dissector. I like to do that pretty commonly. You can see here, Dr. Rivas has already cut the inferior vestibular nerve and is rolling the tumor back.
So Nick, can you pause that for 1 second? Yeah. So that raises a very important question, I think, when you're trying to distinguish retrosig from middle fossa approach, right? Yeah. Is, with those multicentric tumors, I got into, I think you're going to defer to Sarah on this, but, trying to distinguish inferior vestibular origin from superior vestibular origin, trying to use really high definition MRI to see if you can differentiate that, number one, and then number two, VEMPs versus calorics and all that kind of stuff. Do you guys look at that at all and try to distinguish that? Because if you got into a middle fossa with this and you found out it was an inferior vestibular nerve tumor, that'd be very difficult, right?
Yeah, no, that's a good point. I don't know, Sarah.
Yeah, so that is an excellent point. So you can use VEMPs to help you differentiate a superior vestibular nerve tumor from an inferior vestibular nerve tumor. So for those who don't know what a VEMP is, it's a vestibular evoked myogenic response. So what we do is we put sound at about 90 decibels through the ear, and then we measure a reflex response in the SCM. So when you hear a loud sound, this muscle tightens. And in patients who have a superior vestibular, and that's thought to be mediated through the superior vestibular nerve system, basically. And so when you lose your VEMP in a patient who has a relatively small tumor, you may think that that is then a superior vestibular nerve tumor. I don't know that that's certainly not 100% reliable, but it can be helpful. We don't do a lot of electrocochleography, especially for tumor identification per se. I think imaging and high resolution T2 imaging is probably the most helpful in trying to figure out which one the nerve, which nerve it comes from. But sometimes you can't tell. You kind of just have to go in and open the dura and see which nerve looks weird.
Yeah, I think I totally agree with you. It's not 100% dependable by any means, but I was just wondering, it would be a nice tool to somehow facilitate and use, Sorry, Nick, please go ahead.
No, you're fine. No, I think that's a good point. The closure is pretty routine. We've discussed that already. And the post-op film looked good. We were able to preserve hearing nicely for that case.
Did I see you stitching in fat there?
No, I think we were using a dural substitute.
Okay.
Duragen or I forget what we used, bovine pericardium or something on that patient. Here's another case, 36-year-old woman now, a younger patient, again, tinnitus, vertigo, normal hearing, 96% word recognition score, small tumor, you can see here. So how about this one, Ashok?
Yeah, I'd probably defer that one to middle fossa. It's so far out there.
Right, that's what we thought too.
Yeah.
Would you consider not operating? Just
at 36, I mean, you can give her a trial of observation, but I think the problem with it is I think she's so young, right? I think that if the tumor, you're dealing with two different issues. Number one, if the tumor is significantly bigger, I don't know what you quote for hearing loss, even with a 1 centimeter tumor, still something like a 40% risk for hearing loss, if not greater. So the smaller the tumor, I mean, the easier it's going to be to discern, right? So I think there is a price to pay for waiting if the patient's motivated for surgery as well. And so I would lean towards early intervention if you're going to intervene.
Right.
The other thing so when you look at the natural history of these, especially small tumors, so people who come in with 100% word understanding, so totally stone cold normal word understanding, tend to preserve that word understanding over time much better than patients who come in, even if they come in at 98%, and this woman came in at 96%, the natural progression is that she's going to lose her hearing over time. You don't know when that's going to happen. It could happen next week. It could happen 10 years from now, but she probably will lose her hearing in that year. So I think that is part of the calculus for some of these patients as well, and how important is it for them, in their lifestyle, with their job, to try to preserve that hearing, with the understanding that yes, you may, we can try, but you may lose your hearing. But if we save it, it'll be stable.
So yeah, Sarah, this is our case from a couple of weeks ago. I think you've discussed some of the nuances here of opening and harvesting some fascia over the temporalis muscle for later closure.
Oh, this is when the neurotologists do the craniotomy.
Well, yeah. 3 hours later.
Okay.
But in any event,
Great.
you want to discuss anything with the drilling here?
No, actually, this is the video that I think we showed earlier, but
No, it's different. It's a
oh,
different
is
case.
it?
Yeah.
Oh, they all look the same. What can I say? Right. So I think again the key is really in that distal part of the IAC to stay on top of the IAC, because if you go off on either side, you're going to get into the ambulated end of the superior canal, or you're going to get into the cochlea and the facial nerve. And so that distal third of the IAC really requires a lot of patience and meticulous dissection. And it can be hard to see. So what you have to do, which is not necessarily super evident in the video, is that, but you have to flatten the bone out over the top of the cochlea, which is a little bit nerve-wracking when you're starting to do this, because you're like, oh my God, I'm going to drill into the cochlea. But you won't. If you don't expose the geniculate, you won't drill into the cochlea. It's below the geniculate. So that, I mean, those are just some, you know, little anatomy tidbits that help keep things safe.
And
What I
just to
noticed here is that the retractor's not even in here.
Right.
it's
you
the
know.
first thing I remove.
No, listen, so you don't like it, but if you can get the brain relaxed enough by draining CSF out, if you've got a drain in, or releasing it out of the posterior fossa, you can take the retractor out. You don't need it.
Yeah, I don't think you can take the tumor out well with that thing in there. So, but
Well,
to orient the viewer, you can see the semicircular canals here, to the left. The facial nerve, these are tough cases. I mean, the facial nerve is right here. You can see it to the right, and you just have to kind of work around it. Again, I like to use the stimulators, a dissector, and then sharply cutting it off the superior vestibular nerve at the proximal end. And, invariably on occasion, there's tumor hiding up around the corner. You see that there that you couldn't see?
mm-hmm.
And you kind of have to dig that out. It's easy to get fooled and leave that nugget behind. And there's nothing worse than looking at a post-op MRI with tumors still there. And God forbid, you failed to preserve hearing on top of it. That would not be great. So here, it really pays to just look out at every corner up and around the nerve. And then the closure, as Sarah showed quite nicely earlier. So she did very well. So here's another case. This is a 61-year-old woman, slowly progressive hearing loss, right ear, mild vertigo. This tumor has grown, initially treated with the observation, but her symptoms progressively worsened, and so a scan was done at 3 months, and it grew 3 or 4 millimeters in size just in that short interval. She's got some hearing loss, but her word recognition score was still reasonable, 72%. So, Ashok, what do you think about this one?
Yeah, I would definitely go ahead and proceed. That's pretty rapid growth, right, for a tumor.
Yeah.
Initially, I was going to say if she had not demonstrated that growth, 72% word recognition score, there's less to lose if you just wait 6 months and keep dragging it out. But in this situation, growing 3 to 4 millimeters, I think, you're at 12 to 15 millimeters size right now. You'll be rapidly getting into a bigger surgery. Any chance for hearing preservation is, sort of out the window at 15 or beyond. But I think it's worthwhile to go ahead and even if hearing preservation, I would say, is very high risk for this operation, but still I would go ahead and do retrosig as opposed to translabyrinthine. And I think that, hopefully you might be able to see and preserve cochlear nerve, but if not, I think certainly that's dealer's choice for retrosig versus translab, but I would hesitate to just go ahead and sacrifice hearing and do translab on that,
Right, that's what we thought too.
There's an ABR in that picture. I just want you to know that.
I think you snuck in and put it in when I wasn't looking.
I think the other thing about these particular tumors, as they knuckle into the stem, at the point where the eighth nerve is coming out of the brainstem, there's really very little separation between the cochlear component and the vestibular component. And so if you have a big tumor that's pushing right at the root entry zone, I think it's really hard to effectively remove all of the tumor and preserve the functional integrity of the cochlear nerve in that place.
Yeah, no, that's true. And I think, you have to be realistic with the patients. You tell them you're going to try and get the tumor out, but, the chance of preserving hearing is relatively low in our experience once they get up over 15 millimeters. And, I think it was worth a shot. And, in this case, we did get lucky. Here's the IAC drilling. We've shown previously, and then dissecting the nerve out of the canal. Cutting the intervestibular nerve and removing the rest of the tumor. Making sure that's free. And then here you can see at the brainstem, what you're talking about, Sarah. You can see here, though, here is the eighth nerve. And the strategy here is just internally debulk the tumor and really just try and preserve a plane as long as you can and just see how it goes. And in this case, we were able to do that here. The seventh nerve is to the left. I like to find that very early in the dissection. I think it speeds things along. And here we're able to peel it off the eighth nerve and leave. Here's the eighth nerve to the right, the sheath, and removing the rest of the tumor that's attached to the seventh nerve. You see curving around the back of the tumor. Here's what we're left with at the end: eighth nerve to the right, seventh nerve to the left on your screen. And we were able to successfully preserve hearing in this case, but really it just depends on your intraoperative findings more than anything.
I think the other thing about that tumor in particular is that there was a plane, right? So many times they're real sticky, and you can't tell how sticky a tumor is going to be, but when they're stuck, the ability to save hearing goes way down. Yes,
that's true. You can see here there's a little bit of enhancement right along the eighth nerve, just a little bit of tumor capsule that I left. Here's our last case. It's a 47-year-old woman. She actually presented with left facial twitching, and this tumor had grown over the last couple of years. In fact, was diagnosed initially 8 years ago and treated with radiosurgery, but now, again, as noted here, has become symptomatic with documented growth. She has no hearing at all on the left side. So what do you think about this, Michelle?
I think this, is that a tumor on the right side as well?
No.
Okay. Yeah, so, a couple things. Obviously, the facial twitching, with the history of Gamma Knife, that's a little bit harder to interpret, but that's fairly concerning for possible facial nerve involvement or tumor. So I'd make sure I discuss that with the patient about what do we find during surgery. And, once they fail radiosurgery and they have growing tumors, I think that, certainly operation after that is more difficult. The surgical planes are a little bit tedious, and the facial nerve, just like the last, it's never going to just peel off of there easily. It requires sharp dissection and intent to do the dissection. And so, certainly it's big enough and the patient's young enough that I think surgery is warranted, but you just have to go in with a little bit more conservative approach. I do think even in these post-radiated cases, even if you leave a small amount of capsule adherent to the nerve and have a functioning nerve afterwards, residual tumor in that circumstance doesn't necessarily grow. And so I'd rather go back in if I had to, either with a translab approach or not, and resect tumor. So retrosig versus translab, once you've decided surgery is the right thing to do, if you want to really try to identify facial nerve as early as possible, you can consider translab in this patient who's had hearing loss already. So I think that's very reasonable. There's not a big, large posterior fossa component, so I think translab or retrosig is perfectly okay.
Yeah, I think those are really good points. We tend to do quite a few translabyrinthine resections. I think, as you mentioned earlier, the team that you have assembled really helps dictate your choice of surgical approaches in many cases where there's equipoise. And I think, you're also guided by the anatomy and so forth. So yeah, we went ahead and did a left-sided translabyrinthine approach, and we'll discuss this in more detail for the purposes of the course in our next session when we're digging into part 2 of the transmastoid approaches. Again, as you mentioned, the problem with these previously radiated tumors is really the plane between the tumor and the normal anatomy. I found it to be most problematic at the cerebellum and brainstem interface, and then again, as you mentioned, where the facial nerve runs along the back of the tumor, and so here, once the drilling is completed and the eustachian tube is packed, opening the IAC, identifying tumor within it, and early visualization of the facial nerve within the canal. But again, that helps you only so far. Really, it's identification of the nerve at the brainstem that's going to allow you to have any chance of successfully removing as much of this tumor as you can. And you can see here opening the pre-sigmoid dura. This is the first step in this sort of approach. You can see the Dandy's vein and the fifth nerve. And, this is what we're talking about. You can see thick arachnoid and scarring here. But we do identify the seventh nerve early on, even before I do any significant debulking. That's very helpful in terms of going back and forth and keeping the course of the nerve in your mind, as you can see here, as you remove the tumor. Again, stuck inferiorly at the brainstem interface. And you're right, Ashok, another good point. A lot of sharp dissection is required until you get, as shown here, you really just peel it off, because it just won't come off, with mini curettes and the facial nerve monitors a dissector. You can see here, though, a nice result at the end. The facial nerve identified here, very typical course.
Yeah, I think that two things I saw. The use of irrigation, right? That makes stuff a lot less sticky.
Yes.
And then whatever does peels a lot better under the force of irrigation than it does just with traction.
For sure.
But,
I think that's very true. Mm-hmm. We'll talk about closure methods next week or in 2 weeks, but fat graft and seal is very important. Obviously, you can't reconstruct the dura with the translabyrinthine approach. And so closure and meticulous closure technique is very important. And you can see the fat graft here in the postoperative MRI and a good resection of the tumor. She actually did very well, did not have any significant facial weakness postoperatively. So with that, we'll conclude this week's session. Any other comments from Dr. Mowry or Ash Thagiri?
No, thanks for having me, and sorry that we couldn't do this in person. I love Cleveland, if you can't tell. That's my Browns helmet and my Buckeyes helmet. So maybe next year, hopefully, we can get together and enjoy some time there.
Absolutely. I think the other thing is that, there's more than one way to skin a cat. And the key is to know the strengths and the weaknesses of your particular team and utilize those to your advantage.
Oh, you're talking about surgery. I see.
Yeah, sorry. I'm not a football person. I'm sorry.
Okay. All right. Take care, everybody.
We'll see everybody in 2 weeks. Okay.
Bye-bye.
Bye-bye.